again, I wanted to welcome everyone. This is Let's Talk Dental. This is a BioLays webinar series, and we're excited to welcome Teresa Duncan as our speaker. The lecture this evening is called Billing, Coding, and Revenue Tips for Today's Modern Dental Practice. We are hosting tonight's webinar, as always, on the Zoom platform, and we do welcome your questions during the lecture in the Q&A feature in the lower toolbar of your screen, and I'll be in the background monitoring those questions. We will wrap up tonight's session with a few minutes to address audience questions with Teresa. So feel free to post your questions during the lecture, and we'll be sure to try to get to as many as we can at the end of the session. At the conclusion of everything tonight, I will provide information about BioLays Education CE process, along with additional web resources you can access to continue your learning journey in laser dentistry. Tonight's webinar is being recorded and will be posted to our webinar library in the coming days, and you can find that library at our education website at education.biolays.com. So with that, let me formally introduce our speaker, Teresa Duncan. With over 20 years of healthcare experience, Teresa addresses topics such as insurance coding, office manager training, and patient conversations. Her memberships include the National Speakers Association and the National Association of Dental Plans. She has been named one of the top 25 women in dentistry and is the author of Moving Your Patients to Yes, Easy Insurance Conversations, as well as a contributing author to the ADA's annual CDT Companion Guide. Her podcast, Nobody Told Me That, and Chew on This, provide regular coding and management updates. Teresa received her master's degree in healthcare management. So Teresa, thanks so much for joining us again this evening. We try to do this a couple times a year, so great to have you again, and I will let you take it away.
Awesome. Thank you so much, Joe. It's always nice to talk to the BioLays crew. And, sometimes when I'm on the road, somebody will say, hey, I heard you speak to BioLays. So it's cool that you guys come out, especially some of you are East Coasters. It's 8 o'clock right now, and we still got to keep our energy up, right? So what I have on the screen is a QR code that's going to take you to get all of the handouts, but I also have some extra resources for you. I'll talk a little bit about AI and appeals, and there's some information in there about that. And if you don't get it before I change screens, don't worry about it. It'll be up at the end of the presentation as well. The reason why BioLays reaches out to me to do these webinars is that one of the biggest issues that we have today, especially with the economy, the way it is, with the cost of staffing going up, the cost of pretty much everything going up, is that it's harder and harder to be profitable in our offices. And so if you're feeling like, what is going on here? I haven't hired new team members, but my expenses have gone up and reimbursements maybe stayed the same or have gone down. You're not the only one. This is something that all offices are talking about across the country, whether it's patients deciding not to show up for appointments, no-shows, cancellations, and all of that. Why am I bringing all of this up? Because if you are looking to be as profitable as possible, you have to streamline as much as possible. You have to have good billing and collection systems in place. So we're going to focus a lot on the billing and the coding piece of it, because truly when we get those things in place, when we get a good system going there, then recapturing the revenue from patient billing, that's kind of the last mile. But if we do it really good on the front end, maybe we're going to be able to collect all of it so we don't have to chase it down. Another issue that we're seeing in our industry is that the cost of technology is high, and at no point in dentistry has it been moving faster. So we're seeing a ton more technology, expensive technology. It's not just lasers, it's radiology, it's your AI, it's all sorts of stuff. And it's hard to balance the want of having the best and the most, the best for your patients with, can I make this actually work? And so many practice management consultants, many CPAs will be honest with you and tell you it's great to have toys, but if the toys are not bringing in ROI, or if the toys actually cause you to go into the red, meaning you're not profitable, then we can't really do that. So one of the biggest places that I see people losing revenue, leaking revenue, is when it comes to their coding and their documentation. So we're going to talk a lot about all of the different codes that are involved when you can use your laser, and how we're really going to be able to make it so that your clinical notes, your documentation is going to stand up to scrutiny, because I want to at least nail that piece. That piece of whatever I submit is going to be evaluated. We know it's going to be looked at by a dental consultant reviewer. And will it withstand that scrutiny? So I'm going to mix in some of the contract information that I see out there, some provider processing information that I see out there. And again, you're going to get all of these slides. You're going to get a PDF of all of the slides. So don't feel like you have to screenshot everything. I'm giving you everything. And the reason being, if you've taken any in-person class with me, I really want you to listen to what I'm saying and absorb it, not worry about writing everything down. But my goal is to make sure that you're going to go back and disseminate all this information back to your team. I can't be in every office. It's impossible. You all are going to have to be the coding and documentation experts in the office. So my saying, since I've been speaking on insurance, has always been your documentation is going to drive your revenue. As good as an insurance coordinator as I am, as a biller as I am, it's not going to work if I don't have the clinical notes and I don't have really good diagnostic images. And unfortunately, that's so easy to fix. And that is the worst thing that I see when I go into take a look at what's going on with the billing system. So maybe you can get a head start on it and get ahead of that. So, because honestly, if you nail this part, this conversation we're going to have tonight, if you nail this part, the rest of it is going to be, then you're really attacking the big issues that, maybe one plan is really not paying well. Let's get into it. And maybe that'll make a little bit more sense as we go through what the insurance carriers are looking for. And also, not just the carriers, but your state board and your judge and juries that are taking a look at anything that has to do with your records, should it come up in a case. What are they looking for? They're looking for the most complete notes. They are looking for their clinical notes to not just be in a SOAP note format. You all are familiar with that, but they're looking for them to basically recreate what happened in the appointment. And so I'm not saying you have to record everything and transcribe everything. What I'm saying is, when I look at your chart notes, your clinical notes, would I be able to understand that the patient was thrilled with their treatment because they made a comment and it was written down? The patient had concerns about implants versus partials. The patient had difficulty after the third injection. All of that has to be located in the clinical notes. And unfortunately, we're so busy, sometimes that just doesn't make it in there. So they should be as complete as possible. And why I'm going to keep hammering this in is because not only is it going to help you should a legal battle come up or a state board issue come up, but what the carriers are now doing is they do not want your narratives that are written by, maybe it's written by you, doctor, but a lot of times it's written by the staff. And so this was a trend that started in 2018. And every year I see more and more carriers that are like, nope, don't send me a narrative, because the narrative they know is written by a non-clinical person, typically a front office person, but it's also what we consider to be not contemporaneous, meaning we don't know when that narrative was created, and it should be right as really close to the time of service so that it is contemporaneous. Well, what better than just for me to be able to screenshot your clinical notes? The other issue that we see all the time is that the intraoral images, the radiographs, they're not labeled and they're not clear. And a lot of times, even the radiographs, they're overlapped or cone cut. And the issue with that is that benefits are not able to be paid out. So the dental consultant reviewers who review your claims, they have guidelines they have to go by. They're not actually able to pay out on anything if the information that they're reviewing is not diagnostically sound. So if you've got somebody in your office who just says, well, no, I can never get that x-ray done, I can never do this, it's just not good enough anymore. And the other thing that I want you to think about, and this is something that I know sometimes I come down hard on doctors, but I really do it because I'm just really concerned. The fact is, would you go into court with a cone cut, with an open bite, with a radiograph that does not show the apex? If you are feeling lucky and you want to go into court and you're fine with those radiographs, I really can't say much. But I am going to guess that most of you would be pretty alarmed if you were going back through your charts and thought, oh my gosh, you're right. That x-ray wasn't good enough. Why did I go ahead and go forward with it? And that's what I'd like to avoid. Now, the other piece is a lot of times we ask for records from the previous treatment that they had at other offices, and they don't bring them in. Many times patients don't even bother to reach out. So if that's the case, make sure in your comprehensive evaluation that that's noted, that patient, requested that records be transferred, patient did not provide previous records. So if a carrier is asking for previous data service and, you say to them, well, patient stated it was over, the crown was placed over 10 years old, or 10 years ago, and they say, no, it's not good enough. We don't have we need the records. Well, you've got it in your notes that you requested the records, patient didn't bring them. So you've done everything that you can. And then it goes back to the patient at that point. So I get that that's not the ideal scenario, but you can see when I recommend something, it's because I've seen it happen. And I know that these questions are going to come should you be in the middle of an audit, which nobody likes audits, I'll tell you. So how do we do the best documentation that we can? So no matter what you end up doing, whether it's osteosurgery, whether it's redoing a bridge, all of that, you initially made an evaluation in order to diagnose this. So whether it was in a limited evaluation, then of course you're definitely noting chief complaint and all that kind of stuff. But a lot of times it's new patients walking in, and we do it during the comprehensive evaluation, or if there's signs and symptoms of perio present, it's a periodontal evaluation. So if we are doing a complete, taking a look at everything, and you diagnose that they need crown lengthening, they need to have a crown placed, all of that, it's going to take place in your comprehensive evaluation. And what's really great is if you have an assistant that's good at documentation, that assistant can then be there making sure that this is all noted. Me, as your insurance coordinator, when I go to submit the claim, I'm going to get the relevant radiograph, make sure it's clear. I'm going to screenshot a copy of the clinical notes from today that show everything that we did. And then I'm going to go over to the first date evaluation, the comprehensive evaluation, and I'm going to screenshot any notes that were made about that particular condition. So I've got a really good, complete clinical record there of that one particular item. So, but again, you can tell if I don't have good documentation, or maybe if we were in a rush that day and we weren't able to get to it, then you can see how that really falls apart. So templates are super important here, and it takes one person. I usually will assign it to the person who is in charge of insurance once a year. Typically, it's the beginning of the year, to go through the templates, and you're going to need to update them if there's any new dental codes that come through. Remember, every year we get new dental codes. Some dental codes are deleted. So you're going to go ahead and make sure that those are edited. And then if there's a new procedure, talk to the doctors and find out what kind of template what are we going to put in the template for this particular procedure. So I really need you to get in the habit of updating your templates on a regular basis to make sure that they are current and can really help you when it comes to coding. I'm going to go over a couple different codes that are laser specific. And you can see that I'm looking at benefit booklets to find out, how can I tweak my templates so that I have a better chance of obtaining reimbursement. Now, be careful, because what I didn't say was how I'm going to write my records so that I can obtain reimbursement. How could I add to my template so that if this situation happens, I have it there. So, and I'll give you some examples as we go through. Full probing once a year, because that is standard of care according to the AAP. So you should have that. And I remember a doctor telling me it's really hard to get my hygienist to probe every 12 months because, sometimes she's busy. And I thought, I understand. I get it. I was a manager for years. I know what those conversations are like, but doctor, with as much grace as I can give you, that question is not going to fly if you're in front of a state board. So my answer is irrelevant. It's, can you go into the state board or a court and stand by your decision to not obtain that standard of care data. So intraoral images, definitely very helpful for many reasons now. And so many of you that's part of your workflow. So that's actually pretty cool now. I remember starting when it wasn't. And then radiographs, for the most part, benefit decisions are going to be made if the radiographs are current, and usually the limit is 24 months. I have seen some plans where the x-ray needed to be within 12 months, but I'm going to venture that most of you're not going to do anything unless you've got a current radiograph, so that you know exactly what you're getting into. And I think that's just a really good rule of thumb. So you have the repair perio protocol. So if you're a laser, if you're a BioLase customer, you have a ton of documentation that they've given to you. And it's basically just as complete as possible. I took the surgical phases and the post-surgical phase, and I went ahead and added in some of the most appropriate codes, some of the codes that you might find yourself using. And so you can certainly, go back to this particular presentation and take a look at it and see if it's very helpful for you. I know a lot of offices, when they really get to use the laser on a regular basis, they will create explosion codes or multi-codes with this, and then just, put them on the ledger and then take out the ones that aren't applicable. So you have this list of codes here, and feel free to keep it. I just want to call out something here. The reevaluation visit D0171, it's an evaluation code. It actually shares frequency, most cases, with the limited, periodic, and comprehensive evaluations. Well, this code is one of my favorite codes, and it's just criminally underutilized. I see many doctors that do look-sees or quick appointments, and there are no charges after treatment. I don't like that. We are in a very competitive arena right now, where it's not free for you to provide a look-see appointment. The cost of labor to make the appointment, clean the room, schedule the next appointment, talk to the patient, your disposables. And, I'm just going to put it out there as a joke kind of, but you guys get it. Like, you went to school and you paid a lot of money to be able to make that quick 2-minute assessment. So, that's something that I think you should be compensated for. So I would love to get rid of the look-see appointment or the quick check appointment. The proper evaluation code is 171, and many times it is reimbursed. Does it share frequency again with the evals? Sure, but not everybody is going to have a plan that covers everything. So as an industry, we need to get okay with understanding that benefits aren't going to apply for every procedure that we're going to do. And many of you are taking this course because you've seen that. So I get that. So the documentation for laser usage for periodontal procedures, and this I take directly from BioLase's documentation. If you're going to go in and adjust your templates, this is a really good start. And one thing that I would probably add in here, just because I like to add these things, is any comments that are made by the patient. So, do they feel okay? Do they feel like their mouth is cleaner and all that? And sometimes at the reevaluation appointment, they feel like, wow, it's very healthy. I don't have that bad taste anymore. I don't have, that weird feeling. And that's all information that should be documented, because it shows healing. It shows that patient's been keeping up with their at-home care. Just what it does is it paints the complete picture of the care that you're providing. So you've got a whole bunch of stuff here. I think one other thing that I would add onto here, and I apologize, I don't think it's on my slides, but time seated, time dismissed is something I have recommended starting to add to all of my clinical notes. And the reason being, many of you have heard this already, for scaling and route planning, many of the carriers, if you are triggering an algorithm or so forth, and they think that they want to take a better look at what you're doing, they will request a copy of the schedule, or they'll just send the insurance coordinator back a note that says, please give us the type of anesthesia that was used and the amount of time that was in the chair. And it's gotten to the point now where I will put in, I'll have the doctors put in time seated, time dismissed, we already have the anesthesia stuff in there. But when I take a screenshot of the clinical notes, it's going to include the time that they were in the chair. And I'm not going to promise that that's going to avoid it, but I have noticed, and so have other people in my audiences that get back to me on this, that they don't get as many requests for that. In fact, I feel like they don't get requests for that at all. So I would just maybe take a look at adding that in. Another place that I would add that into is if you're doing same day crowns. There's a lot of times where, maybe the carrier reviewer doesn't necessarily know that this is a same day crown appointment. Maybe they skim your notes, but this is a good way of showing that, hey, patient was here, waited for a little bit during this time period, and then here they were reseated and crown was placed back on. So you can see, like, I'm getting very detailed on my clinical notes, but to be honest, as an industry, we're moving in that direction. So I'm not really even going to get into this too much because it's definitely it's a very big conversation, but the trend in medicine is that the patient should be able to see his or her own records. They can request it and they can see it. Right now they can, but we are going to be moving to a point where records are going to be able to be accessed by portals. And so, if that makes you nervous that, well, my records, I don't like that. I don't like the patient seeing my records. Now's the time that we've got to get our house in order, because that's coming down the pike. If you're not already doing it, there is going to be a time when it's going to be mandated. I feel very comfortable in saying that, just because I know that that's where the industry is going, and that's where CMS, Center for Medicare and Medicaid Services, is pushing us in that direction as well. So many of you are having a really good soft tissue management program in place. That's fantastic. That's why you're on the call. You're like, how do I make this work? So the question that I get a lot of times when we have a good discussion on perio coding is, how much are we doing with the staging and the grading? Well, we're at the point now, it's standard of care. It needs to be included. So if you've got a patient with periodontal disease, well, we've got to find out, and it's got to be in the notes, what stage did they present to you with? And then how is the healing? Is the healing happening? Is there no healing? Is it rapidly decreasing? Is it just going downhill? And that's what the grades are. So the question that I was starting to get in class, and you have this, so you can take a look at it. And if you're not familiar with staging and grading, I would say this is a really top priority thing that you need to talk about in your class, because everybody in your class, in your office, everybody in your office should be aware of staging and grading and what that actually means. Having good conversations with your patients and understanding grading, staging is really crucial, so that the patient understands how urgent getting this done is. The fact that it's tied into systemic issues. I mean, you can see here, you've got risk factors like diabetes, HbA1c is at certain levels. They have it here on the staging. Do they have any other comorbidities, any disease state that we're going to be working with? And so that's something that you need to make sure is in your notes. And so I kept getting questions of, well, where do I put it in my notes? And so there's a small template for you. You're welcome. Hopefully you will use it. Stick it into your templates for the initial evaluation, the comprehensive evaluation, and then of course the continuing care visits. So this comes into play, the continuing care visits, it comes into play when you run into a benefit plan that is only going to cover perio maintenance for 24 months. And that's a very common clause. And so they only cover it for 24 months. Well, what that means then is at the end of 2 years, it's not, I don't think your patient's automatically gets out of the chair at the 2-year mark and is healthy again, but your grading at that point showing that the disease is still progressing, if they're not able to get scaling and root planing access again because of benefits, if you can do it, but if the benefits aren't going to be there for it, then you at least can make a case for let's continue with that. I also have been successful appealing it with a grade, and let me just go back here, a grade of B, where it's a moderate rate. There's the disease is still progressing, but we've been able to, they were initially at a C, and then we've been able to reassess and at a B. And so they're moving the continuum. And what we didn't want to do in this particular case was we didn't want to go into another scaling and root planing situation. Patient was really doubling down on oral care. And so we were able to get that extended for another year. And at that point, then there was going to be a reassessment done on whether or not they should continue on with another round of treatment. But we only were able to get that extended because we were able to show that there was continuous monitoring of the disease state, and there was a grade relevant to the patient's, actually represented the patient's situation. So staging and grading definitely needs to be part of your documentation. Again, not just because the carriers are looking for it, but because I would never want you to ride into court and not have this information for a perio case. I know a lot of lawyers, and many of them are extremely good at their jobs, and many of them are going up against you. And so that's why I say let's get our house in order. So let's talk about SRP, because these are the questions that I get the most. Typically you have 24 or 36 month frequency limitations for that. It's always going to require perio charting. I'm not telling you anything you don't know. What you need to have is clinical attachment loss that's going to show on the perio charting. And I remember the one of the consultant reviewers telling me that they get perio charts where it's just spot probes in different areas, and they just know that the level of care is probably not up to par for this patient, and taking a look at radiographs and all of that. So they told me, I appreciate when I get a very colorful perio chart, because I know that they took the time to accurately assess the patient and document the patient's condition. And so could your perio chart be as colorful as possible? Probing depths, bleeding, pus, furcation, all of that stuff that is all different colors on all of our charts, right? I gave you an example here of intraoral images, and I know it's dinner time for some of you, I'm sorry, but I think we're all kind of numb to this, right? So here's an example of the intraoral images and the radiographic images. They're of the exact same teeth. And this is why it's so important that having the intraoral images really helps complete. I mean, the radiographs by themselves, I could see, some back and forth, but it really does help to see the complete picture with what's going on with the intraoral image. And so I am always impressed with some of the cases that I look at. People will call me and say, hey, just can you take a look and make sure we're doing okay? And the intraoral images are just so clear and so descriptive. So if you've got somebody who's good with the camera, keep at it, because I think it's fantastic. So another, so let's go to this, because I know this is the question that I always get. And it has to do with, of course, LBR. And with the reason why you purchase the laser, I'm going to guess, because remember, I'm not clinically minded. I just know the codes really well. I was an assistant for a while. It wasn't a really good time, I'll tell you that. But here's the thing. I'm guessing that you bought the laser to provide better care, to get better results, better outcomes, and maybe even get a little bit faster and just more predictability, right, with your outcomes. So what is unfortunate is that a lot of times I feel, well, and it would be nice, right? I feel like when you buy a new technology piece, there should be a direct line between purchase and ROI, right? From a coding point of view, I can't draw that line. So we'll talk about that just a little bit. As far as outcomes, clinical outcomes, healing, you all can draw that line, right? Unfortunately for me, it's not that simple, but I'm going to try as best as I can to help you, be able to talk to the patient about it. So LBR, there is no code that accurately describes it. So that is why we're using 4999. And, if you're doing work around implant that's got implantitis, that you have a code that you can use, the 6999 code. for that. Unfortunately, when you're in network, there's a lot of bundling and stuff going on with the codes, right? So the question I always get, well, what do I do if I'm out of network? Well, if you're out of network, I'm not saying you can bill whatever you want. You bill consistently what you typically bill, but you don't have to worry about that because you're 4999. You're not worried about it getting bundled, and you can price it, of course, as well as you can. Now, here's the issue. Excuse me. Oh, excuse me. All right. It's been a long day of phone calls. I was telling Joe today, this is my last time in front of the microphone today. So it's kind of, I think my throat's just thinking, oh, okay, that's it. So I read a lot in Facebook groups and some of the forums, and there's always somebody that's saying, let's use a form. Let's have the patient sign a form. And it basically is saying, you can bill the patient whatever the patient understands, and then you can basically circumvent any participating provider contract that you've signed. Now, in some cases, I'm okay with that, and we'll go over that. In some cases, it's not appropriate because when you sign the contract, you agreed to be beholden to their rules and regulations. So the extra mile that we need to go to when talking about this is that we need to look at contract language, and that's something that not a lot of people do. So I really am wary of platitudes such as you can always have them sign a form, or you can just have them, don't send it to insurance, just tell them it's not going to get covered, don't worry about it. So the problem becomes, and this is where I see the most amount of issues and resulting audits, is that the patient realizes by either talking to somebody or calling the insurance company that they actually didn't need to sign that form because that's a procedure they probably wouldn't have had to pay anyways. But where I see it the most is that the patient attempts to get reimbursement from their HSA or FSA, one of their flexible spending accounts, and those will not pay out unless there's a denial of that service. And so then that starts the phone call to the carrier, where the carrier says, well, did they have you sign a form? Well, yeah, they did. They told me you guys aren't going to cover it. And can we just at least fill this out so that I can at least get reimbursement from my FSA? And then the insurance company says, well, you can revoke it. And then that way you actually don't owe anything. And then there's a whole conversation that happens there. So if you are going to use the HIPAA release form, which is one form that you can use, basically you are going to be using that form and it's going to apply to everything you do that day. And you're going to have to bill the patient for everything you do that day. You can't pick out LBR and bill in the scaling and route planning. And you're actually going to be billing them at your full fee because the HIPAA release form actually says you're not using their insurance. Well, you can see that's really problematic. Okay. Now I know that this is just it's complicated. So if you didn't get it the first time, this is getting recorded. You can go back and listen to it. And I know many of you are going to actually play it for team members too, because this is not one of those where I can give you a quick answer in a forum. This is a nuanced answer. So let me get into why. So in the Delta Dental Dentist Handbook, so for this current year, they have policies in place on saying, laser technique, laser disinfection, it is not a covered benefit. It's not billable. And so you will see that in there. And if you're a participating provider, unfortunately, you've agreed to be bound by that. Now, there are policies, even Delta policies, where if you look at the individual employer policy, if you ask the patient to bring in their policy, which is called a certificate of coverage, then that policy may actually allow you to bill for LBR. But the truth is, not many of us are able and have the time to go into that kind of detail. And if we do, you're probably a fee for service or out of network office and can do that. But when you're in an office and you are in network and you're hustling, something like this is really hard to get a hold of. So in my longer classes, I talk a lot about how we need to get in the habit of asking patients to bring in their actual plan document so that we can look for these terms. And so I'll give you an example. This is for next year's, the Blue Cross Blue Shield FEP dental plan, the one that pays out, not the one that's just like $8, but the one that pays out. So in this, they have a general exclusion, things we do not cover. And in that situation, you actually can bill the patient for it because it's not covered. And nowhere in the plan, this is the plan plan documents that the patient has access to. In here, they actually will say services that are for specialized procedures and techniques are not covered. So in this case, I would be quite fine with billing the patient for that and making sure that there is some sort of signed consent that the patient is aware that it's not going to be covered. And now that is the key that I want to get across to you. We have to be transparent in our billing, and that is going to reduce the angst. That's going to reduce the number of people that come back at you and want to know, why did you bill for this? And I was told this. So let's be as accurate as possible. If your plan, if the plan that you signed up with has a general policy that says you can't bill for it, I would look to the plan documents that the patient actually can access. They can get it from their HR portal. If you see something in there that says specialized procedures and techniques, that LBR falls squarely into that. So I've been very comfortable recommending this because I have checked with several lawyers, but I know I would never recommend it until I actually see the plan document. And so that's the difference here. I don't want you to just start using forms here and there, because those forms in a court of law, state boards, they don't care about your forms. They don't care. So make sure that you're doing it correctly. Okay, so let's move on to some other codes here, because I know we have a couple other codes to get through, and I anticipate you're going to have questions about what we just went through. I know, because as often as I explain this to audiences, I still have to be very careful that I'm being as descriptive as possible, because coding 20 years ago is not coding today. It is complicated. The poor insurance coordinators that are out there listening to this class, I feel your pain. It is not like it used to be. It is really hard nowadays. Okay, so let's talk about osteosurgery. So with osteosurgery, we do need to have really good documentation there. And what I want to see is you really taking a look at your template and making sure that it's going to show that, for example, I found this in many manuals that go over, the provider processing manuals that go over what are the benefits they would pay out, in what instance they would pay for osteosurgery. And I saw very often this fourth bullet point: crestal bone level should be greater than 2 millimeters below the CEJ. So doctors, is that something that you're often putting into your templates? Now, again, I'm not saying put it in there, even if it's not true. That's not what I'm saying. But if that's what you're seeing in the mouth, why wouldn't you include in that? And then me as your coordinator screenshotting it, I'm already like at home plate, because there is the documentation that is going to show to the dental consultant reviewer, this meets the criteria of this particular plan. So the code states bone has to have been augmented or removed. And often reviewers, I've sat through tons of claims reviews in my life where the consultant reviewers take a look at everything and they go over why they denied or why they approved. There's always discussion. And in many cases for osteosurgery, there's nothing about any bone being augmented or removed. And the code specifically says that. So another tip that I'll give you, and I have it on the last page, is that put into your budget every year to buy the ADA's coding companion guide and the CDT code book. Buy it. Every year it's updated. Every year that coding companion gets thicker and thicker, because there's all sorts of different scenarios in there. And that's the book that you're going to go, if you get called into court or the state board, that's the book that they're going to use. I want you to, do you see what I mean? Like, you need to know what the sources are for that. So what are they looking for here? If there's a history of traditional SRP, many plans are saying that they will pay for osteosurgery only after SRP has been completed previously. But if you come across a patient who SRP is just a Band-Aid at this point, your staging is going to show that in the notes. So your staging, radiographs, and probing is going to show that. So I just wanted to give you that information there. And osteosurgery, I know that that's the other big procedure that is being done with the laser. And I'm really, honestly, it's getting better. I do see a lot more documentation when it comes to the bone being augmented or removed, but it's such a simple thing to add into your templates, because I'm pretty sure that's what you're doing when you're using the code. So we've got gingivectomies. Gingivectomies are very frustrating for me. I know that they're needed, but from a biller point of view, there's always a little bit of sadness when I see a gingivectomy, because if I'm looking at a in-network plan, and sometimes they're restrictive, the gingivectomy is often what we call disallowed, meaning denied, it means you can still bill the patient, they're just not covering it. Disallowed often means that not only are they not covering it, but they're telling you you can't even bill for it. And so I hear from doctors all the time that I'm giving away gingivectomies left and right. And I would have a very good conversation about, are you actually losing money by participating in a plan? And gingivectomies is one of the metrics to look at when you do write off a ton. A lot of times it's gingivectomies is the culprit. And then we see a lot of the 4999s if you're in a very heavy laser practice and you don't know to look for this language we just went over. And so many times I will see crown buildups being denied and not appealed. And that I think is another big issue with our offices is we don't appeal half as much as, not even a quarter of what we should. And the studies are out there, not the studies, the data is out there. Most offices do not appeal at all. And so that's how you learn as an insurance coordinator, right? But gingivectomies, unfortunately, this is the documentation that I'm going to tell you to use in your notes, because this is what I found in the provider processing manuals. But if you're in network, that's something that I would still appeal, even if it says disallow. I would still appeal, because perhaps you're able to talk to a dentist that, okay, they see that it's done. They know that you did the extra work. And in some cases, I've talked doctors through how to talk to the consultant reviewer, and the consultant reviewer is like, you know what, you did the work. Let's just, instead of flat out disallowing it, let's just deny it, and then you can bill the patient. So I'm not going to promise that's going to happen all the time. In fact, that was not a common occurrence at all. It's happened maybe 10 times in my lifetime. But I know that from talking and knowing the consultant reviewers, they're quite aware that gingivectomies do take extra time and care. So I don't have the best news when it comes to gingivectomies. So what about crown exposures? Well, they are not reimbursed typically on the same day as restorative procedures. Well, and of course, definitely they can be seen as cosmetic. So here's what my conversation is with the patient, that it looks like your employer's plan, the way they want us to do this is they want us to do a procedure one day and then have you come back and finish it another day. In our professional opinion, and I would say this as your coordinator, not as the dentist, in the doctor's professional opinion, that is unnecessary. He or she would like to do it all in one day. They think it's going to be the best outcome. It's going to be the most ideal treatment. Your employer, unfortunately, selected to break up benefits for that. So we can do it that way. It's not ideal, but we should actually do it all in one day. But I do want to let you know that that's something that's not going to be covered. One of them is not going to be covered if we do it together on the same day. So crown exposure is something that I don't see disallowed often. I just see that straight out denied. It's usually one of those non-covered services because it is seen as cosmetic. I always tell the patient I'm going to appeal, but I always point out to them that this more than likely is not going to be covered. And so I would, if I can get it covered for you, Mrs. Jones, I think that'll be great. But I'm just going to go forward putting this in your column because I usually do see this being non-covered. And everything that just came out of my mouth, I know some of you, especially if you're brand new to dentistry, you're like, that's not going to come out of my mouth like it came out of her mouth. I know. It didn't come out of my mouth that well either. I tripped all over words the first couple of times. I had good conversations, but the more you know and the more you do it, and doctors teach them all of this stuff so that they're very comfortable with the clinical aspects. So the more you do it, the easier it's going to get. Okay, so crown lengthening. This is another one very similar to the conversation we had about gingivectomies and crown anatomical exposure. Here's the thing. Many benefit plans are going to only benefit for it if it's done on different days. And sometimes that's not the case. Now, crown lengthening, many of you do decide to do it on different days. But what I want to get to, I guess, is just because it's benefited in this manner does not mean it's clinically appropriate. What that and the carriers will tell you this. We're not telling you how to do treatment. We're telling you how it's going to get paid. And we can argue back and forth on the semantics. I know. But to be honest, in their language, they're saying the benefits here, you as the doctor are empowered, of course, qualified to treat the patient as you see fit. And so if you decide to do it and the benefits don't line up, I'm not going to be cold hearted and say, oh, well, but I think as an industry, we've tiptoed around this a long time and really started making benefit guidelines our clinical guidelines. And I'd like to not see that. And it's an easy descent. I mean, it's an easy slide into that. So what I always see in manuals is bone recontouring. So if you're going to do clinical crown lengthening and that's part of it, let's get it into your template. All right. So we also are going to need to make sure that there is a reflection, the full thickness, flap, and removal of bone. And that is something that I typically don't see. I don't typically see anything about crown to root ratio in there. And the pushback I get from doctors is basically that the pushback I usually get is that it's obvious with the radiograph and that, but it needs to be put into there. So again, don't assume that it's another dentist that's going to read it. It could be a jury that's going to read this and they're not going to understand it. So let's be as clear as possible. So we've got the frenectomies and frenuloplasties, all these friend words, they don't roll off the tongue that well. But you've got codes for that. And this is where the laser is just phenomenal. I have a lot of friends that do pediatric billing and just, it's so good for the kids. But I do want to say, let's take a look at medical billing. And if you've never done medical billing before, I'm not saying dive into it just because you've got a laser, but there's an awful lot of procedures that could be picked up by medical billing. So if you're ready to make that commitment and learn about it, please do so, because I do see offices actually recouping a lot of money on that reimbursement that typically wasn't there, and it's available through the medical plan. The thing is, I do not teach medical billing. I'm terrible at it, so I'm not going to teach it. Joe's going to have to find somebody else who's really good at medical billing to do a webinar. I am just not the one. I will never get your medical billing claims paid because I am that bad at it. But there is some hope for you if you do decide to go there. And my personal opinion too is that we're probably about 4 years away from having conversations about medical billing being pretty prevalent in the dental office, for good or for bad. So I'm still on the fence for that. You also are able to use your laser for biopsies and excisions. And typically, if you do it on the same day as a corresponding restorative procedure, it's not going to be covered, but that doesn't mean you don't do it. It just means you're going to have to make sure that the patient is aware that there's going to be something out of pocket. Many times we do this because patients can only come in once or twice. Some of my friends that are out in the Dakotas or Wyoming, their patients can't just pop in every day. They're 3 hours away, right? So if there's extenuating circumstances like that, I would absolutely use that. Going back to getting things paid that normally are not covered, I've been very successful at getting 4 quads in one day covered for patients because they've had medical conditions that necessitated them not going off of medication like the blood thinners, or they've got some sort of some other comorbidity. Maybe they have caregiver issues where they have to rely on someone else to bring them to the office. So there's all sorts of extenuating circumstances where 4 quads in one day is going to be able to be paid. So you just don't know until you appeal. And again, there goes that conversation we just had where let's appeal everything. So you've got hemostasis, like making the clot happen. This is something that's included with the procedure, but I'm telling you, medical billing, this is something that I know that my medical billing friends are able to get, if they're doing it as part and parcel of a medically covered procedure, they're able to wrap that all in there too. So I'm constantly surprised by how much medical billing is advanced, and just do your due diligence, find a good teacher. For those of you doing endo and using laser, but just endo in general, medical billing has started to open up in that arena, because what's happening is we're learning how to document the need for laser treatment with endo better. And so as our documentation gets better, I think it's going to be harder to do some denials, right? Speaking of denials, let's talk about that. So typically denied, I really don't see these covered. Of course, I don't see them every day, but when I do, I typically don't. I check in with a regular group of billers, and this is not something. This is definitely medical. I would take a look at that. But the point is, when you have a laser, what that's going to do is your outcome is going to be great. Okay, so that actually is just a phenomenal reason to employ that. But the healing is good. The procedure is fast. You're going to get faster. There's of course the wow factor that patients just love the fact that they're not like in pain that maybe I don't want to say no pain, but that much. But you as a clinician, you're utilizing a really good tool to do that. And so there's kind of a give and take here. Like I hate to tell you that there are going to be cases where coding is not going to be great, but on the other hand, you're going to get faster. You're going to have better outcomes. And then my thing is, I think this is going to help many of you really take a look at how much is being written off and how much being in network affects you. I'm not saying go out of network. That's not what I'm saying. There are many plans you can be in network with and it still works. I've met many dentists who are very successful being in network because they know their numbers, they know their business model. So if you are comfortable being in network, you like it, your fees are good, maybe this makes you more efficient and faster, right? So I'm not sure, I don't know everybody's business model, but what I typically see is when you buy a piece of technology and you expect it to be magical, and it is magical in your hand, but I think sometimes that actually makes you open your eyes and go, wait a second. I had no idea that I was paying out this much every time I did this procedure. I had no idea that it was actually my cost of goods, what we call cost of goods. My cost to provide this procedure is actually this. And so that does spark conversations on what am I doing, as far as participation, and you take a look at your participation positions. So some of you, I know from I've done this webinar a couple of times now for BioLays, and I have heard from several of you that you've gone back and taken a look at it and you've realized, you know what, instead of beating your head against the wall about bad reimbursement, it's really opened your eyes to say, look at this, I want to do this treatment, but this is what I have to go up against. And so you look at your worst plans and you cut. You stay with the plans that are going to work for you, and then you constantly reevaluate that position. So let's talk about appeals. And I put this in to the handout in the folder. And again, I'll show you the QR code, but AI has been fantastic. And so if you have not played with AI, this is going to sound like Greek for a minute. If you listen to this a year later, you'll probably be up on it because I just don't think you can get away from AI at this point. But I have been writing appeals, helping people get comfortable with AI to write appeals for procedures. And so on my YouTube channel, I walked through how I used a patient's or doctor's clinical notes for crown buildup and crown. And then I took the clinical guidelines from United Healthcare, put it together, and I asked the AI to help me write an appeal letter that was actually supported by research and articles. It gave me some articles that I would not have used, so I eliminated those, and I was able to use some research articles in that. So it gave me a fantastic appeal letter. Now, the other side of that is that some of my consultant colleagues, they're like, I know when a letter is AI written. So AI tends to just add a lot of words in, like it really fattens up the letter with a lot of extra words. So do your due diligence and edit it. But I've been pretty pleased with the results I've gotten. I've getting ready to record a couple more videos. One of them will be scaling and root planing, and that way you can see, what it takes to write a good appeal letter. And I'm waiting for a whole slew of them to come back because I don't want to give you how to write an appeal letter and it doesn't come back actually paid. That would be disingenuous. So as soon as I get the first round of, hey, those were working, I definitely am going to share what I did with that. So stay tuned on the YouTube channel there. So I gave you the link in the folder so you could follow along with it. So as we kind of slide into the end of the presentation here, because I know I talk a lot and I know I give a lot of information and just a short period of time that I have you. I want to end on more of a conversation between us so that you can have better conversations with your team. So here's where I am with this. For years, I would tell the patients, that your plan didn't cover this. And oh, I'm so sorry, you don't have benefits for that. And I've switched it up in it's been years, but I've been switching it up, and I want to start getting this planted in your head. So when something isn't covered, I want to tell the patient, I definitely am going to tell them it's not going to be covered. I suspect it's not going to be covered. I'm not being apologetic anymore because, if I had the chance to pick their plan, I would have picked a really good plan. But here's the thing that you need to understand. Most employers, when they select a plan, they also have no idea how to pick a plan. And in fact, talking to the brokers that I know, the ones who sell the medical and dental plans, dental is like this last mile. Like people don't even look at that. They're so concerned with the medical premiums. And so they pretty much just sign off on whatever the broker puts in front of them. And so I want us to change our language. I want us to say things like, your employer's plan actually doesn't provide benefits for this. We are going to try our best to find out exactly how it's going to pay. But in our experience, your employer's plan has been pretty restrictive in their benefits. And I gave you a couple different examples in that because, again, these things are kind of flying out of my mouth, but that's because I say them regularly. I've tripped over them. Trust me, I've said really crazy things to patients and then had to walk it back. But I've gotten to the point where I'm comfortable now saying it's your employer's plan. Your employer selected a plan that unfortunately isn't going to provide great benefits. Be happy to talk to your employer and help them pick a better plan next time. But what I'm not doing is apologizing for the plan. So the last line here is something that I use all of the time, which is, I'm really surprised to see that your employer doesn't cover this procedure. We often see plans that do cover this. So it's kind of disappointing to see that your employer selected a plan that doesn't have benefits for this. So what I'm doing is shifting the conversation that should happen between the patient and the HR office, the employer, not me and the patient, because many of us, and if you're an insurance coordinator, I know because I went through years of feeling bad that the patient had terrible benefits, and I still feel bad, but I'm not owning that anymore because I would have picked a much better plan. I think you would have too, right? So what I'm getting across to you is that present the treatment as prescribed. And doctors, don't worry about how the benefits are going to play out. I understand that you need to at least know what the pricing is, but hopefully your insurance coordinator, that he or she is going to get to a point where they can talk to the patient bluntly about the plans like we just went over. They're going to get to the point where they're going to be comfortable looking at contract language to see if something can be billed back to the patient because it is a specialized procedure. They know to look for language that absolutely says no laser benefits at all. And then that way they can go ahead and have a talk with the patient. So if I were to see that, remember that Delta Dental policy that said laser treatment is not benefit, is considered to be part of the procedure. The conversation I would have back with the patient is, I'm really surprised to see that. Laser treatment has been around for years. The doctor invested in a really wonderful piece of equipment in order to do this faster, and that so you wouldn't have, be in the chair for hours to get this work done. It's faster, it's more efficient. I'm so surprised that it's not covered. It is extra because, and if you are allowed to charge for it, this is why we decided to use this. And I would actually even call in, talk to your doctor, make sure you're not lying, of course, but the doctor strongly feels that the outcomes are going to be better. He sees much more healing when he uses the laser. She would not treat this using the older tools that are typically used. This is a perfect case for using the laser. These are all conversation pieces that I've heard doctors use. And so it's the patient that needs to hear how important the treatment is that you prescribe. And so when we give power to, well, your insurance isn't going to cover this, and we have to do it this way because otherwise your insurance won't cover it. What we're doing is actually giving some power to that, right? And we as an industry really need to refocus that the real prescriber of treatment, the real prescriber and partner in health is actually the dentist, not the carrier. And knowing as many carriers as I do, carrier representatives as I do, they actually, most of them would agree with me on that. They don't want to be seen as the one deciding treatment. They always tell me we decide benefits. And again, you can, semantics, whatever, but that is really their message. So all that being said, if you would like more insurance information, I do have an online course, and you can do that. It's self-paced, year access, so you're welcome to do that. I do have a book called Moving Your Patients to Yes, Easy Insurance Conversations. It's small, good book club material. I am working now on a book called Fearless Financial and Case Presentations, from my years of presenting cases and talking money, and it's just going to be chock full of verbal skills and scripts and examples and all of that. So I just hope that helps all of our lives be easier. And again, I want you to put into your budget the CDT 2025 companion guide, and they have an app. I know only the most geeky of us are going to love that. But that is something that you need to put into your budget every year, because the codes change every year. And I hope that your team doesn't turn over, but if your team turns over, we need to get them up to speed and trained as well. It's a lot of money that flows through your practice, and coding and reimbursement is where the money leaks. Time after time, my colleagues who do billing, that is what they tell me. Fairhealthconsumer.org is down here on the bottom. And what that is a site you can go in and put in your zip code and procedure code, and you'll find out what the 80th percentile is in or out of network for certain procedures. And so if you've ever wondered, what that looks like, you can certainly check that out. And if you feel like listening to more of me talking, you've got 2 different podcasts. Chew On This is more fun. We talk about different things that are going on in the industry, teeth talk. So teeth trends on TikTok, which is not anything I watch, but it's very interesting. But nobody told me that is more insurance and management issues. We do deep dives into topics. And so that being said, I know I think I heard Joe unmute because he's going to do some housekeeping here. There's the QR code again, if you would like the handouts. And again, it's a folder that's got a whole bunch of different handouts in there too, so that you can print it out and be the expert in your office. That's how you find and connect with me. And Joe, do you have any housekeeping that you want to do before we wrap up? I know we're right at the top.
Yeah. Well, first off, thank you, Teresa. That was wonderful information as always, super helpful and detailed information. And it's almost like you've done this before, because most of the questions that we got were around some of your resources that you offer through your Odyssey Management consulting company. So to our audience, I'm going to leave it on this page for a little while so that you can scan the QR code there, because there were quite a few questions about anything from the presentation, which I'll get to here in a second, to handouts, to other resources that you provide. So I would encourage our audience to scan the QR code, go to Teresa's website, go to her YouTube channel. All of her resources are wonderful, and that will be a great way to continue learning through her resources, but also to continue your dialogue with Teresa and have her help you at your practice. Teresa, I think the biggest thing that I'm looking at here is 2 things before we wrap up. One is kind of fee for service question here that I thought I'd get to, that's laser specific. I don't know if you can lend some advice here, but what's the average fee that you see offices charge for like laser bacterial reduction when using a diode laser?
Yeah, so it's really, I hate to say it, but it's kind of all over the map. I mean, I know offices that are billing, about 49 a quadrant. I hear 19, I've seen as high as 99 a quadrant. But I have to say that sometimes when I ask, why is it set at that fee? There's this kind of grumbling of, well, it's because we're trying to make it up because this fee and that fee. And it's like, no, that's not how we do it. Let's actually look at our cost on that. So really, how long is it going to take you to do that additional disinfection? And what is the comfort level of the person doing it? Because they're the first couple of times they use the laser, as you know, Joe, many dentists don't charge for that actually because they're still getting good with it. But what I do see is, then they get comfortable with it. I would say anywhere between 49. I would say 49 is an average fee, but unfortunately, because 4999 is one of those where we can't actually go into Fair Health and put the fee in there. Now, we can't. So I guess that was the best guess I could give you.
Okay. And to that audience member, I'll give you our email address to our education team, and feel free to reach out to us and we can give you some more guidance and information on that topic. Before I move on, there was a question about coding for other areas. I think it was specific root canal therapy. I did want to point out that, Teresa did mention the CDT companion and the guidebook. I think correct me if I'm wrong, Teresa, but it's important to keep up to date yearly on that companion and that guidebook because codes do change. So that would be my first advice for that person. Any other advice that we should mention before we move on, Teresa?
Sure. Yeah. So with the root canal, again, the benefit companies, they basically say that it was a means to an end. It's not that you use this particular modality. It's the fact that you perform the endo. So the same reasoning for scaling and root planing. And so there aren't any specific laser codes for root canal. You could utilize the 999 code 3999 because of the endo category, but that is there again, there's no specific laser codes for that. Yeah. Right.
Yeah, thank you for mentioning that. Okay, to our audience, for additional information about our educational resources, I would urge you to go to education.biolays.com, or you can just go to biolays.com and you'll see education listed in our main menu there. There's also circled resources. Those are two of pretty heavy resourceful areas of our website. So those are two areas that I would encourage you to go to if you're current laser users. First you can go to Waterlays Academy. Once you go to our education website, obviously, if you own a Waterlays or are interested in getting into Waterlays, which is our all tissue laser, that's going to be the area of our education site that has all things, related to all tissue laser education and treatment. There's also an area of the site called the Epic Diode Academy, and that is focused more on the diode laser wavelength with videos, with clinical videos, with cases, with different types of online and virtual courses that you can take. So those are the two academies that we have: Waterlays Academy, Epic Diode Academy, and you can find those at that education area of our website. Now, a couple of you asked about this presentation. We do this about twice a year with Teresa, and we always record them and we post them on our webinar library. When you go to our education site and you scroll down, you'll find our virtual and online education area, and you'll see our on-demand webinar library. You can click on that. We have a billing and coding section that you can click on, and there you'll have Teresa's recorded webinars that you can re-watch. Now, as we add other live webinars to our schedule, Teresa, this is our last one of 2024, crazy enough. So this is our last this is our last one of the year. As we schedule new webinars for 2025, we'll post those links to register for those on this area of our website. We also have some really cool podcasts you can listen to, and just basic Laser 101 intro courses that you can take online. And then finally, to get your CE for being with us this evening, you must be officially registered. Attendance will be recorded via Zoom. And the most important thing, if you've joined us before, you know this, but you will receive a survey via email. You have to complete that survey to get your CE certificate. So give our team a day or so and then look out for that email. Take the survey, you'll get your CE certificate. If you don't see it, just check your spam or your trash. It should be there in the next day or so. So again, if you do want to reach out to the BioLays education team, education@biolace.com. Very easy. Just reach out to us. We'd be happy to answer your questions and help you. Again, you can go to biolace.com and find out so much more about our technology. View this webinar, learn more. So I would encourage you to go there. Teresa, thank you so much for spending the last hour or so with us and sharing your knowledge. Really appreciate it. And to our audience, thank you for joining us, and we hope to catch you at our next webinar. Thank you and take care.
Thank you.